participants from the University of Texas Southwestern Medical School, the University of Cincinnati College of Medicine, the University of Chicago Pritzker School of Medicine, this is Audio Digest Surgery, Volume 17, Number 5, the week of March 11th, 1970. This week, guest surgeons Charles R. Baxter, Bruce G. McMillan, and Harvey A. Ziram offer some practical pointers on the treatment of burns, from the diagnosis and clinical aspects of septicemia to the techniques and adjuncts of skin grafting. Recorded in Chicago at a Cook County Graduate School of Medicine seminar on burns, Dr. McMillan is first up with these guidelines on treating septicemia.
The clinical picture of gram-negative as well as gram-positive sepsis, I think it is important. We recognize these differ rather strikingly in many respects. Relevant to the course of gram-positive is rather insidious in nature, extending over a 2 to 6 day period, as opposed to gram-negative sepsis, which is rapid, usually fatal within a period of 12 to 36 hours. Disorientation, which is common with gram-positive, is usually absent with gram-negative, people being lucid up until the last hour or two prior to death. Hypothermia, I think, of all, may be the most valuable prodromal sign relevant to impending gram-negative sepsis, and this is something which can be anticipated usually prior to the time that we get into difficulties with the wound and other problems. Mortality rates relevant to established gram-negative sepsis at the present time, in our experience, is between 33 1/3 and 50%, depending upon which modality of therapy is being used and the period in the post-burn course at which the first evidence of sepsis is noted. In this day and age, there should be no mortality from gram-positive organisms. Now, relevant to the clinical picture at the level of the wound, this is the organ we're concerned with. Over a 24-hour period from a very healthy red granulating surface, within a relatively short period of time, there is very little granulation tissue left. There's an obvious overgrowth of Pseudomonas aeruginosa organisms. There is free fat, and there's a perfect portal of entrance for bacteria, for local dissemination, and in certain cases to systemic dissemination. Now, relevant to other clinical manifestations, usually ileus is associated with this, and this is probably on the basis of toxemia, as well on the basis, in some cases, of embolic septic hemorrhages and infarcts which occur throughout the gastrointestinal tract. Any patient at this stage, usually between the 14th and 21st post-burn day, who has ileus, this should be a signal for further investigation to establish the diagnosis and initiate treatment. The obvious implications of ileus, the problems which are associated with retrograde peristalsis with acute gastric dilatation, and a review of one's autopsy material indicating a high incidence of aspiration during this period of time, should point out the importance of treating these patients with some form of upper gastrointestinal suction. These patients should be probably put on a Wagenstein suction and Levine tube, probably small in nature, to prevent, during the acute phase, acute gastric dilatation and aspiration. The cutaneous gangrene problem, in our experience, is one which is a very serious prodromal manifestation of the disease. I think, without exception, in our experience, anybody with established cutaneous gangrene on the basis of any gram-negative organism has not survived, even though they have been on maximum therapy for gram-negative sepsis. Some of the other problems, and another important consideration, pulmonary complications relevant to gram-negative sepsis, Pseudomonas aeruginosa, septicemia, and pneumonia, is universally a fatal complication. It is a progressive degree of lack of perfusion despite increases in oxygen and supported ventilation. PO2 levels fall and PCU2 levels rise, and this usually ends up as a fatal problem. An interesting corollary of this is some of the work that was presented by Dr. Damick and others at the Surgical Research Unit, and subsequently in some of our research material. One can correlate in a limited number of ulcerations of the upper gastrointestinal tract, a correlation with either gram-positive or gram-negative septic infarcts in the submucosal layer, cutting down on the normal defense mechanisms of the gastrointestinal tract, making them more prone to ulceration, and possibly representing a cause of and an explanation for the close correlation between bleeding and sepsis in the late post-burn period. An approach was initiated in Atlanta, Georgia by Dr. Harlan Stone in trying to get some information relevant to establishing evidence of Pseudomonas sepsis at an earlier date rather than the clinical manifestations which we have already discussed. The basis for this is the demonstration of Pseudomonas infection upon the burn wound, and this can be related grossly to quantitation of burns, and this is usually burns over 15 to 20% of the total body surface. However, it can be seen in patients who have Pseudomonas pneumonia. The Pseudomonas aeruginosa organism does inhibit at the slime layer toxin level the breakdown of vertiglobin into biliverdin, and as a result puts out vertiglobin in the urine, or the so-called green urine syndrome. Now, the green urine syndrome is not as frequent as it was before because we're not seeing as much Pseudomonas sepsis with the new type of antibacterial agents which we have available to us at the time. But this is, I think, an important refinement in therapy if one does have and can demonstrate the presence of vertiglobin, because it gives us an indication of colonization of the burn wound in a magnitude which may be a potential hazard to the patient with Pseudomonas colonization. And we have been using this as a method of initiating therapy at an earlier phase, hopefully at the time before the necrotizing papillitis and the necrotizing vasculitis problems are noted. This is a rather simple mechanism to accomplish. A simple Woods light can be used next to the patient's bedside or in the laboratory. By ultraviolet illumination, those urines which contain vertiglobin positively fluoresce. There are false positives associated with this particular approach, and one should be aware of this if they use this as a mechanism for determining the impending sepsis from the Pseudomonas organism. And false positives do occur not due to sepsis in the immediate post-burn period as a result of hemolysis of red cells following transfusion reactions, septicemia with hemolytic type of organisms other than the Pseudomonas, and following major surgical trauma, which is probably related through the breakdown of red cells. And vertiglobinemia without hemoglobinuria has been noted to follow the vaccination with the Pseudomonas vaccine, which Dr. Alexander has developed and is using in our unit. This vaccine being obtained from essentially the same layer that causes the inhibition of vertiglobin into biliverdin. A further refinement by using the spectrophotophotometer for determining the presence of vertiglobin in the serum as well as in the urine. And by using a spectrophotophotometer, normal urine and vertiglobin urine patterns differ. This can be accurately assessed with a spectrophotophotometer. And we have also noticed that this can be obtained within serum as well as within urine. The importance of the serum determination is that in our experience this can be seen some 5 or 6 days before vertiglobin is demonstrated in the urine, giving you even a further lead time for the use of more specific anti-Pseudomonas drugs. Now, if vertiglobin is demonstrated, we do utilize systemic gentamicin therapy. And I think it is important to point out that the level of therapy should be either at 2 levels, either 1.5 or 3 milligrams per kilogram per day. It should not exceed the 3 milligram because this is a level which will exceed the 12 microgram level per cc, which can create over a long period of time a toxic situation. If we are using gentamicin as a prophylactic drug, which we rarely do, we use it at the 1.5 milligram per kilogram level. Positive vertiglobin and the evidence of gram-negative sepsis, it's used at the 3 milligrams per kilogram per day level. Gentamicin, as you are aware, is FDA approved at the present time. It is approved for intramuscular use. However, it can be used and in limited situations has been used by the intravenous route. The maximum dose, according to specification, should not exceed 1 gram per total course of therapy. We have extended this to 5 grams without difficulty. However, I do not recommend this unless you have specific indications. Relevant to toxicity in animals in concentrations of 100 times greater than those used in humans, one can show ototoxicity and nephrotoxicity, but at 3 micrograms per kilogram, this is not a level which is prone to give difficulty relevant to toxic end results. And I think as far as diagnostic measures, another rather simple thing that we can do relevant to trying to establish the diagnosis of colonization of Candida albicans on the burn wound, a gram smear made from the burn wound may be confused with a gram-positive rod, but with a little additional manipulation by the use of the hanging drop method, using the microscope again on the floor in the close proximity of the patient, and looking at it immediately and without resorting to culture techniques, making it possible to establish and quantitate the occurrence of the pseudopods of the Candida albicans on the burn wound and taking necessary measures to prevent further colonization. The treatment for Candida albicans in general, if possible and reasonable, consists of discontinuing antibiotic therapy, trying to reestablish a normal flora, instituting nystatin therapy by the gastrointestinal route as well as by the topical route, given by mouth in children. This is 400,000 to 800,000 units per 24 hours, given in 3 doses. And only, and I would like to point out, the use of amphotericin if there is a deteriorating situation, a life-threatening situation relevant to the Candida albicans. However, if amphotericin is used, it should be given in the dose of 0.25 to 1 milligrams per kilogram per 24 hours. A maximum dose should not exceed 2 grams over a period of 10 weeks of time.
Dr. Charles R. Baxter moves to the speaker's platform now as he reviews the fluid and electrolyte requirements of the burn patient.
In the experimental data on dogs, we concluded that the quantity of fluid it takes to resuscitate a burn is not dissimilar from that had been described from less exacting studies. But the most important factor that seemed to be responsible for animal survival was the rapidity of administration with alleviation of all the physiologic defects. Now, we extended this formula to humans as an absolute formula in the beginning. And let me say that I'm going to describe to you what we did in humans on an experimental basis and then attenuate this in light of other things that are important in resuscitating burns as far as fluid management is concerned. So we did extend to humans an absolute formula of 4 cc's of lactated ringers, balanced salt solution, per kilogram body weight per percent burn, all administered in the first 24 hours. And in the second 24 hours, the patient receives only maintenance water and certain electrolytes such as potassium, which may become very low in the second 24 hours. And this is their total resuscitation. Now, I emphasize this very specifically because as one attempts to make the transition from the ingrained teaching of 48 to 60 hours to resuscitate a burn, if one gives this much fluid in 24 hours, you have replenished the deficits that have occurred due to salt loss at least, and no further saline-containing solutions are necessary and in fact may be detrimental. Now, let's compare this to a Brook formula in a 50% burn. In terms of a 50% burn then, we are talking about 4 cc's in a 70-kilo man in a 50% burn. This would be a total of 14 liters of isotonic solution administered to the burn. Let me emphasize that this is balanced salt solution. Sodium and Ringer's lactates 130, and the chloride and bicarbonate are balanced in the same proportions as they are normally present in the bloodstream. So that the use of saline under these conditions as a substitute for lactated Ringers, or employing Normasol or other solutions which contain an excess of chloride may create problems. So we are specifically talking about balanced salt solutions in this type of formulation. Now again, the total would be 14 liters for a 70-kilo, 50% burn. If we compare this to the total quantity administered by a Brook formula, we come out fairly close to the total volume of fluids. For in the first 24 hours, we would have given, by the Brook formula, a total of 0.5 cc of colloids. Now, most colloids have a sodium concentration of over 140 milliequivalents per liter. For example, plasma in ADC solution, as you employ it from your blood banks, has a sodium concentration of between 160 and 200 milliequivalents per liter. So it is mildly hypertonic, in fact, moderately hypertonic, depending upon how much ADC and so on is in the banked plasma. And in this same formula, we'd give 1.5 cc's of lactated Ringers for a total of 2 cc's per kilogram per percent burn. Now, this would total in the first 24 hours 9 liters. In the second 24 hours, we would then give half that amount, or if we then total the quantity given in 48 hours by a standard Brook formula, and plus the 2 liters of water a day recommended for urinary excretion, or that is allowing for the formation of urine, etc., we come out with a total of 14.5 liters of total volume replacement. So this just emphasizes that we're talking about a difference in time only, that the quantity is very nearly the same. Now, in terms of administration of the amount of sodium, milliequivalents of sodium that is given. If we figure colloid as an average of 160 milliequivalents per liter, then one would give approximately 1,440 milliequivalents of sodium by this formula. Whereas with crystalloid resuscitation, balanced salt resuscitation, the total sodium administration absolutely was, in the patients which I'll describe to you, 1,820 milliequivalents. Now, this is about 2.5 liters difference in terms of isotonic expansion. And when the series at Brook was reviewed, the majority of patients in recent years were found to have exceeded the quantity of fluid recommended as a guide by the formula. So that we're really not talking about a difference in volume, we're talking about only a difference in time, but we are talking about different fluids, for we have not given any colloids to this group, which I will describe to you. Now, when we look at the reconstitution of extracellular fluid and plasma volumes using crystalloids alone, we find that if we measure their volume spaces 24 hours post-burn, which we are able to do with long curve or 6-hour equilibrations because they are fully resuscitated, and we can hold these patients without the administration of any fluids for 6 hours at this point because they're fully resuscitated. And therefore the volume studies are more likely to be, and probably are, accurate. We found in varying percent of burns that we have come close at 24 hours to restoring the extracellular fluid to the 20% of body weight, and in the larger burns, slightly over. Now, one can explain this overshoot in several ways. Perhaps it was too much fluid. Perhaps it was. But if one takes an animal and changes collagen by burning, one finds that 5 days after burning, the extracellular fluid space has increased. Dr. Francis Moore showed this in trauma patients or anyone subjected to severe surgical stress, that within 3 to 5 days following injury, the extracellular fluid space was normally increased for a variety of reasons. So that I don't think this is as significant an overshoot as one might imagine. A significant deficit here at 24 and in many instances at 48 hours was a plasma volume still below normal. Normally, serum protein should be about 4% of body weight. We are generally below that until 24 or 48 hours post-burn. Certainly, a plasma deficit below the estimated normal for these individuals is present. And at times, in some individuals, this may be as much as 25 to 30% below the expected normal for such a burn patient. Now, I emphasize this because I want to come back to it as to what it means in terms of a later study. But to reiterate again, we're talking now about the results of crystalloid alone. And we have shown that they have reconstituted their extracellular fluid volumes completely with a mild plasma deficit still present. The response of the circulation was the same as in animals. Within 24 hours, and usually within 12 hours, the cardiac outputs were returned to normal, and in most patients, save the incinerated burn or the elderly burn, these cardiac outputs remained within a normal range through the entire period of total resuscitation, or that is the end of the first week. In addition, correction of the acidosis was also maintained well in these 150 patients. pHs were generally returned to normal of 7.4 within 12 to 18 hours post-burn, and then became mildly alkalotic, again re-emphasizing the lesion in the pulmonary circuit as having been measured many years prior to these particular studies. Excess lactate is still present in a burn patient and is usually double normal at the end of a 24-hour post-burn. But excess lactate is below any clinically important level. Now, the essence of response is in what happens to the patients. First of all, the urine volumes are no longer 10 to 30 cc's an hour, which in any other type of patient we would call oliguria. If you had a surgical patient that was only putting out 20 cc's an hour or 400 cc's a day, you would call this oliguria. Yet for years we were willing to accept this as a normal volume for a burn patient. These urinary volumes vary between 50 and 70 cc's per hour. Secondly, the patients are lucid and relaxed. they are not apprehensive and restless, which certainly one could attribute to the injury itself. But I think in retrospect we can attribute those signs principally to a compensated shock type of response. For we do not see the restless patient complaining inordinately of pain, which is difficult to diagnose. These patients complain of pain commensurate with their injury. If it's second-degree burn, they tell you that when the wind blows across it, it burns like the very devil. When they have the pain of arterial insufficiency from swollen extremities, it's that deep ache that is well recognized, and one can do a skenotomy or, if necessary, a fasciotomy and return flow to an extremity. Now, in these patients, we measured central venous pressure, which I would recommend to you in any patient receiving volumes of fluid of this magnitude. Although we don't feel that it's necessary in the burn patients, it's still an awful good adjunct to use with massive fluid resuscitation in any type of patient. We found it very difficult to raise the venous pressure to 3 or 4 centimeters of water. On no occasion did we see venous pressures rise above 6 or 7 centimeters of water unless their cardiac outputs fail to respond. So in those few individuals whose cardiac outputs would not come up, then we would see a rapid rise in venous pressure at some stage during the resuscitation. Otherwise, if the heart was capable of responding, this quantity of fluid has not produced, as evidence of circulatory overload, any rise in central venous pressure. A fourth advantage, I think, to rapid administration is that in general the pulses in the patients are below 110 per minute. In the past, we were willing to accept 120, 130, not too disturbed at 140, although most of us realize that at this pulse rate, stroke volume drops off precipitously, and characteristics of blood flow are certainly changed at this level. At 110, we can maintain such tachycardia as this without any detrimental effect upon peripheral flow. There's a distinct absence of nausea and ileus. We are able, in most instances, to let even 70 and 75% burns have clear liquids at 24 hours post-burn. Most of them are eating at 48 hours post-burn. This does not alleviate the problem of the initial use of a Levine tube for gastric dilatation. In our experience, major traumatized patients, multi-systemed injuries patients, burns, etc., have gastric dilatation on admission, and routinely in burns we place a Levine tube down to alleviate that gastric distension, pull it out within a few hours, and in burns then begin to feed them liquids as early as 24 hours. Again, the acidosis is alleviated quite rapidly, and if one does not have blood gases to follow these patients with, which is highly desirable, one can expect CO2 combining powers to be above 20 milliequivalents per liter by the 12th to 14th hour post-burn. Now, many would perhaps be very critical of this approach to burn shock therapy because they administer large quantities of colloid, with certainly the valid observation that serum proteins decrease precipitously. Dr. Cope demonstrated quite well in the late 40s that the concentration of protein in a burn wound is extremely high, and it becomes necessary in the eyes of many to replace colloid material as a plasma volume expander, hoping to do away with the plasma volume deficit, which I've showed you in the studies which we have done, and many, many studies in the past having illustrated the same thing. Also, we showed, too, that the concentration of large protein molecules, twice and 3 times as big as albumin, flowed into the burned area immediately after burn. So the question to our mind was, one, the need for colloid, which is obvious. Second, when you can give it to have it do the job that you want it to do. It seems rather ridiculous to run in albumin for 24 hours and have it all run out into the burn wound, or 48 or how many. So we conducted a little study in 25 burns, which is all we have totally complete at the moment, in which we gave a pint of plasma at varying hours post-burn, measuring the effect on plasma volume of the effect of 1 pint of plasma given in 30 minutes. And there was some variable in time, but I have grossed this in order to show you the meaning of it. Roughly, before 24 hours post-burn, plasma will not raise the plasma volume a bit better than ringers. And we cannot get the plasma volume up any better with one solution versus another. But at around 24 hours post-burn, and in the individual burn, this varies plus or minus 4 to 6 hours. So in some burns, you can raise the plasma volume at 18 hours. At others, you can't do it before 30 hours. But it's somewhere around this focal point, when one gives a pint of plasma, it raises the plasma volume by the amount of plasma that you gave within the error of the method, which is roughly about 4%. So it would seem that this experiment, at least in the way that I look at it, has married the crystalloid therapist to the colloid therapist, in that we have asked each solution to do, or having it do, what we wish it to do. Certainly we were not happy with the plasma volume deficit, as I don't think anyone else was. But here we are able to raise this deficit to normal at the earliest possible moment post-burn. So that at the present time, our general approach to the burn patient is that we will administer 4 cc's of crystalloid per kilogram per percent burn, roughly in the first 24 hours, and stop. If there is any deterioration in his clinical condition, then we will give a small quantity of plasma, sometimes only 250 cc's, sometimes as much as 750 cc's or a liter is necessary to completely stabilize the very large burns. We have not found it necessary to do this in burns less than 40%, and have found it to be of great aid in many burns over 50%.
Dr. Baxter's presentation concludes this side of Your Real Doctor. On side B, Drs. McMillan and Baxter consider topical burn wound treatment, with particular attention to silver nitrate, gentamicin, and sub-eschar antibiotics. Then Dr. Harvey Zerum analyzes some techniques and adjuncts of skin grafting. To hear side B, simply reverse the 2 reels or cassette cartridge on your tape recorder. A program on treatment of burns continues now on side B of Audio Digest Surgery, volume 17, number 5. Turning now to topical burn wound treatment, Dr. Bruce G. McMillan describes the advantages and disadvantages of silver nitrate.
The solution which is put on as a 0.5% silver nitrate solution is one which is applied as a wet compress. Our dressings are wet down at every 2-hour intervals, are changed every 12 hours, and totally removed and replaced, and then wrapped with stockinette as described by Moyer's group. One of the things which is of help is the use of Curlex rolls. We utilize the wide roll which pre-pack and has made a difference in cutting down the time and also improving the debridement of the application of the dressings. Now, relevant to the advantages of silver nitrate, I think I would like to emphasize one major advantage, and that has to do what we interpret as its effect on evaporative water loss. And if we will quantitate the amount of fluid and electrolyte loss, specifically fluid under these circumstances, per meter square per 24 hours, we will see that under normal conditions, per meter square, we're losing approximately 500 cc's per 24-hour period. The open vessel, which results from a burn wound, will give for this surface area approximately 2,000 to 5,000 cc's per 24-hour period, is definitely reduced by some 33 1/3 to 50% by the application of the wet dressing. I feel that this is not the silver, but is the mode of the application of silver, which has its definite beneficial effect as far as conservation of metabolic expenditure, and this is reflected later on, we feel, in a minimal amount of weight loss in all modalities, which we'll discuss. At the same time, however, there is a potential hazard associated with this method of therapy, and this is the electrolyte loss, which is associated with silver being applied in a hypotonic concentration. And these losses per meter square of burn can amount to 250 to 350 milliequivalents, and essentially the same for potassium and chloride. What this does relevant to the patient, and we do and can get into situations of hypoelectrolemia where we have sodium levels at the low ebb, and in this day and age is rarely necessary to compensate for large losses of electrolytes, but if this be necessary, hypertonic saline solution can be used, preferably at the 3% concentration, in severe losses at the 5% concentration. However, this can be done on a day-by-day basis. This loss can be anticipated And if this program is followed, using essentially 6 to 15 grams per day of sodium chloride for an adult patient with a major burn, 4 grams of sodium bicarbonate, and 15 to 30 cc's of potassium gluconate, one can maintain electrolytes within essentially a normal range and not be concerned with replacement therapy by the intravenous route. Some of the methods by which silver nitrate can be utilized to a minimum amount of disadvantage in the hospital environment is by the use of disposable sheets, disposable gowns and gloves, which minimizes the effect upon uniforms of personnel and minimizes deterioration of hospital equipment. We have, in the early phases, pretty much resorted to the program that they had in St. Louis by actually dyeing sheets a brown color to compensate for the staining, but this is another approach to the same problem. One of the current compounds which is available at the present time utilizing the antibacterial effects of silver is the silver sulfadiazine, which has the same antibacterial aspects of silver, also adding diazine to the preparation, making it possible to utilize the advantages of the preparation, however, not causing staining and difficulty in the surrounding environment. The one thing which this preparation does not do is have the advantage of minimizing evaporative water loss when applied in this manner. And I think as far as silver nitrate, there are advantages which we should consider. First of all, it is non-toxic. Argyria is not a problem. It does have effect upon bacterial colonization. This is mainly through the gram-negative sphere of the spectrum. It can minimize negative to nitrogen balance, as evidenced by minimal weight loss during prolonged periods of therapy. This is reflected in a decreased vaporational heat loss. And it can be used in conjunction with homografting and autografting, which is an important consideration. It should be carried on through the entire period of grafting until reepithelialization is complete. And the disadvantages, one should be concerned about the environment in which it is used. Sodium chloride should not be used in conjunction with it because it will inactivate the preparation. It is ineffective on established infections. We prefer not to use it if we see the patient 3, 4, or 5 days after the initial burn. One should be careful about the use of grease and dead epidermis around the treatment area because this will influence the effect. It does favor production of hypoelectrolyte problems, as we have indicated. It does require extra supplementation of extracellular sodium, etc. And one final complication here is the problem associated with incomplete breakdown of the nitrate to the nitrite ion, this causing a methemoglobinemia, which we have had experience with 2 cases, necessitating the discontinuation of silver nitrate and going to one of the other modalities of therapy.
Next, Dr. McMillan takes up the merits of gentamicin therapy, then compares the effectiveness of silver nitrate, gentamicin, sulfamylon, and sulfur sulfadiazine. Let's listen.
In the initial evaluation of gentamicin in our series on 612 cultures, what the susceptibility of the burn wound flora, as noted at the time some 3.5 to 4 years ago, was. And it is noted, if we see what resistance patterns are, that when we get over 5 micrograms per milliliter as far as concentrations of discs are concerned, we essentially have no resistance at all except for an occasional staphylococci, which is of the epidermis variety and saprophytic in nature. So that with this wide spectrum of effectiveness, and especially in the gram-negative phase, we felt that this should be used on a comparative basis with other effective agents at that time. One of the advantages of gentamicin, it is first of all heat stable. It is pleasant in appearance, it's pleasant to work with, it can be autoclaved, and it can be used in conjunction with conventional dressing techniques. In addition to being used with dressing techniques, it can be used as an onlay type of solution, available either in an ointment form or in a cream form, and can be used in conjunction with temporary preparation of the wound with homografts. We find that the vast majority of our burns are being treated by the open type of technique. However, there still, I think, remains selected use of occlusive dressings in the final stage of preparing wounds for grafting as an example, and it can be used as the interface of this dressing without changing other routines within the hospital environment. What essentially the topical program for gentamicin therapy has been, one must be aware that beta hemolytic streptococcus will colonize the wound and is the reason for utilizing systemic antibiotic therapy in conjunction with it, specifically penicillin, if patients are not sensitive to that agent. It is applied in a 1% either ointment or cream. Our experience has been largely with the ointment in the early phases. If the wound is in the process of being prior to or ready for grafting, we will convert to the cream at that particular time. Advantages, open versus closed. I think is a distinct advantage of this as an agent. Absorption studies indicate that the cream remains in the wound approximately 80% of the concentration which has been applied to the wound for a period of 48 hours, and approximately 90 to 95% of the ointment remains within the burn wound environment for that period of time. Now, as far as advantages are concerned, at the present time, in a comparative study dealing with 59 patients with sulfamylon, 60 with silver nitrate, 94 on gentamicin, and 11 on silver sulfadiazine, in essentially a comparable group ranging between 31% total body burn up to 44%, and essentially the same degree of third. The mean day of autografting, which I think is of interest and may be influencing in selection of such agents, is for gentamicin 30 days, is for sulfamylon 37, silver nitrate 67, and for the silver sulfadiazine 35. In regards to the deaths in the sulfamylon group, while pulmonary complications are paramount in this group, we still have had problems with uncontrolled sepsis in the larger burns, and 2 of these being Aerobacter klebsiella group. As far as the gentamicin series is concerned, sepsis still is a problem, 6 of the 9 deaths being from Pseudomonas sepsis. The mortality rate in these 4 groups, recognizing that these are still small and these figures are probably not too meaningful, 10% or the lowest for the gentamicin group, as opposed to 27 for silver sulfadiazine, 26 for silver nitrate, and 31 for sulfamylon. What we feel at the present time to be criteria for selection of the agents which we feel all are effective in their certain peculiar situations. And relevant to the selection, we feel that for electrical burns where penetration is exceedingly important for control of infection, that sulfamylon is number 1 in choice. Silver nitrate, as we indicated, has been selected only for fresh wounds. Gentamicin is equally effective in the ointment form for fresh wounds, but because of the higher absorption rate of the cream, we go to cream if the wounds are delayed some 2 to 3 days after the initial burn. Our experience with pain with sulfamylon has been moderate. We have not had problems with pain in gentamicin. The removing of dressings with silver nitrate can be painful. However, the silver nitrate as such does not evoke a pain response. Reactions to sulfamylon as a maculopapular rash, in our experience, has been in the range of 10%. A rare rash to gentamicin has been noted. We have had no rashes relevant to silver nitrate. As far as eschar separation is concerned, the eschar is separated, we feel, with sulfamylon, but it should be pointed out that due to the diffusion of sulfamylon, it is possible to do delayed excisional procedures with safety and prepare the wound for grafting essentially at the same time as gentamicin or the other agents. And finally, the availability of gentamicin and the other agents are unrestricted at the present time, and at this moment, one can select an agent to do the job for the particular circumstance at the particular time that the patient is burned.
Sub-eschar antibiotics provide another approach to topical control of infection. Developed simultaneously with the other methods of topical control, but now limited to specific indications, sub-eschar antibiotics are evaluated now by Dr. Baxter.
This came about when all of us recognized with the demonstration of burn wound sepsis as the cause of death in burns at Brook, that our major trouble with systemic antibiotics is they simply didn't get into the wound. It stood to reason then, if our problem is an avascular area of dead tissue to which we cannot deliver antibiotics systemically, it made sense that if one placed specific antibiotics into the burn wound, some effect on burn wound sepsis and therefore mortality would be forthcoming. So after many animal experiments and the test in humans, we developed this technique, which I will describe for you. And that is, if one places a needle into the sub-eschar space and places 25 cc's of any isotonic solution, it will diffuse over an area about the size of a softball in an hour. Our technique then is to look at a burn wound and say, well, it's 3 softballs across and 5 softballs down, and 25 times that 15 equals 450 cc's. That's what it's going to take to cover this area with antibiotic. Into that amount of fluid, we would then place the specific antibiotic, which we would choose on the basis of wound culture, in a dosage acceptable systemically. The only reason for this is the medical legal complications of increasing dosage and so on, and what the optimal dose would be, we really have no idea for any of the antibiotics which we use. But certainly we would deliver into the area which we wish to place the antibiotic a tremendously high concentration due to the diffusion characteristics of various drugs and so on. Now, this single needle is attached to the pediatric drip set, which allows one to control the amount of volume that goes into an individual area. The larger burns, if one uses single needle crisis in these patients, it'll often take 24 hours to cover the areas. And we had the unfortunate experience of negating all additional care in order to cover the area in a 24-hour period, so that multiple batteries of needles are used and the therapy for a single day is completed within no more than 8 hours. We use 22-gauge needles, which are placed run-in just like any other crisis-type administration. Now, what are the complications or the failures of the technique? First, they are the one that you would expect to be: inappropriate antibiotics, not choosing the proper drug on the basis of the wound cultures. Our routine is full-thickness wound biopsies every third day with quantitation of the quantity and type of bacteria present in a wound, and therefore would change therapy on the basis of the changing flora of the wound or changing concentrations of a given organism. We have found that certain antibiotics are not effective by this means. The first is colimycin, for reasons that are not quite clear. Polymyxin is very effective, but colimycin is apparently tissue-bound and is totally ineffective when applied in this manner. It may be the adjuvant in which it is put up. It may be the drug itself. We're not certain. Cefluoridine does not work. We have found it to not control organisms which are extremely sensitive to the drug. Apparently it too is tissue-bound. Erythromycin is extremely painful by this method, and novobiosin, in my opinion, is not indicated. The vehicle is extremely important. If one uses balanced salt solutions containing calcium, they will precipitate in the tissues and cause large areas of apparent necrosis. Therefore, normal saline is employed. One must be very cautious in the most frequent complication which we encounter, and that is fluid overload. For as you can easily see, a 60%, 70% burn may require as much as 4 liters. This much salt load daily will often, over a period of days, lead to overload, and therefore can be circumvented by using half-strength saline. In the same way as we give Clysis to small children and so on, simply use 0.45% saline if more than 2 liters are required. Now, in what patients do we use sub-eschar antibiotics? It is an effective means to control infection. But as you can see, it is much more difficult than smearing something on the surface and tanking the patient. And in any general hospital situation, this becomes a very important factor. Therefore, we have limited the use of sub-eschar to these specific indications. That is, infected burn wounds, either those that escape topical control or those referred late which are already grossly infected. The second category is any burn which begins to grow organisms at greater than 10 to the 4th log, or 10,000 organisms per gram of tissue. The assumption here is if there is an increasing logarithmic growth of organisms in the wound, that it will become a septic wound. Now, it won't always do this, but if one looks at the available data, any wound that's increasing its population is liable to invade, and we all know that wounds colonize several days before the systemic signs of sepsis are present, and that these represent lethal signs of sepsis, not early signs of sepsis. Therefore, we base our therapy upon the increasing log rate in the wound. Third, the results of topical therapy in burns over 40% full thickness is far from complete, and the mortality rate has not been affected to a great degree in burns greater than this magnitude. Therefore, we would use in combination with topical therapy the sub-eschar administration of appropriate antibiotics as an adjunct to topical therapy.
Our third guest speaker, Harvey A. Ziram, summarizes for us the techniques and adjuncts of skin grafting as he considers some practical ground rules in successful debridement of eschar and necrotic tissue, and the use of heterografts and homografts. Dr. Ziram?
We try to keep the patient's sepsis under control until the eschar separates, to hasten this by surgical debridement without drawing blood, without causing pain, and without getting, therefore, into the septic problems that all of us are familiar with in the massive debridement of burns in the operating room under general anesthesia. Once that is removed and one is left with a reticulum of necrotic tissue over areas of granulation where we know if we put on a skin graft, the take will be poor, this is the time then to put on the homografts or the heterografts grafts to finish up debriding the wound, getting a sterile wound, and then to apply your skin grafts. There must be separated in our minds different categories of burns. There is the life-saving situation, and then there is the situation of convenience of getting the working man back to work or the housewife or mother back home. In the life-saving situation, one must be more conservative. In the latter situation, one should be aggressive for economic and social purposes. In general, we all agree that split-thickness skin grafts should be used to resurface wounds. And when we talk about them, we mean roughly in the 1 to 12 thousandths of an inch in thickness. It's thick enough that one can handle it well. It's thin enough that the donor areas heal nicely and even allow secondary use of the same donor area when necessary. The dermatomes available, I'm sure all of you are used to a particular one and prefer it. What works for you is what you should use. The most popular in managing burns where you need rapid attainment of long or a lot of skin is the power dermatome, the brown dermatome, the striker dermatome, which had been an electric dermatome, and now, of course, the pneumatically powered dermatomes are available, working on the same principle, and are said to be mechanically more stable than the electric dermatomes, although my own experience cannot say this. In addition, the Paget drum dermatome and the modification of this, the Reese dermatome, are available. They are slower to use than the power dermatomes, but do yield a wider strip of skin and in many cases a more uniformly thick piece of skin, where this is a factor many times in the hand or on the face. In addition, I would urge all of you to familiarize yourself with the Ferris-Smith freehand knife, which at first is a little frightening, and the English have come out with a cheater, the Humby knife, H-U-M-B-Y, which has a little roll and a guide so that with very little experience one can take a freehand graft. The advantages of this is that, one, you impress the other surgeons in the hospital. Two, you can get into awkward areas. You can use this on the ward. You can use it when some other surgeon has dropped the dermatome the day before and it is no longer working. And of course you can, when you've got practice, move very quickly with the freehand knife. So that I think everyone taking skin grafts from burns should learn to use this. And the additional factor that to me is important many times is that you have absolute control over the thickness of the graft. You see it as you're taking it. If you're a little too thin or a little too thick, you can immediately correct for this. And when this is important to you, which it often is to me, you have a control which is not in your possession with any of the mechanical dermatomes. Now, what is the priority of grafting? To me, it's very clear. Hands takes first priority, with very few exceptions, if any. The reasons are obvious and known to all of us. There's very little leeway in the hands. The underlying extensor tendons, the joint capsules, and the very rapid stiffening of the joints that occurs emphasize that hands must be debrided and resurfaced as soon as possible. Other joints of the extremities certainly take second priority, and not to be neglected are the eyes, the eyelids. This is no problem because all of this can even be done at the bedside as far as the eyes are concerned, and many times we should consider immediate tarsorrhaphy to avoid the edema of the eyelids and exposure keratitis. Certainly the trunk and scalp have last priority. The skin on the trunk and buttock and backs are thick. Many times the deep second-degree burn will heal by the time you get around to it, and contractures in these areas are, for all practical purposes, non-existent. The other important factor in deciding which you want to graft first is that it's important to treat an area as a unit. In other words, to graft a part of the hand and leave the lower arm ungrafted then makes it difficult to carry out proper management of the ungrafted area in terms of bathing, debridement, and so on, because you're trying to protect your graft. So work on one unit at a time so that you can completely debride the unit and graft it, and then you're finished with that one unit. A great deal of discussion about dressings or no dressings, traction or no traction, and I can simply say what I do. I think it has a lot to do with what facilities, what personnel are available to you, and what your own background is. It is very sad indeed, and probably the most common sin that all of us make, to ignore the position of joints and extremities. This is an unfortunate situation. Most children will go into the fetal position and develop severe contractures if these are not carefully avoided. avoided. There is now a renewed interest in traction in burns, putting through skeletal pins, Steinman pins or Kirschner wires into the ankles, tibia, etc., to suspend and maintain the joints in a proper position, especially in children. My own experience has been that this has been helpful in some situations, but that splinting and dressings have accomplished the same thing. Prior to grafting, we have the patient go down to the physiotherapy department 2, even 3 times a day, where they get into the whirlpool. We do the debridement. Physiotherapists carry them through a full range of motion. After grafting on the extremities, I prefer to splint them in order to immobilize the extremity and aid the graft in taking, and of course in splinting, maintain the position of the joint that I feel is desirable. The other problems of the burn wound management, in the first 2 days prior to grafting, I like to take away any grease gauze or greasy dressings, with the theoretical feeling that a thin layer of grease might interfere with the vascularization of your graft. So I use a water-soluble antibiotic mixture that is, in essence, neosporin. It's a combination of neomycin, bacitracin, and polymyxin in a liter of saline. These are used like wet to dry or wet dressings for 2 days prior to grafting.
Follow-up studies of children making physical recoveries from severe burns shows that 80% remain emotionally disturbed. Typically, the disturbance is blamed on the burn experience, pain, and long separation from home. But, in fact, the child's disturbance usually existed before the burn ever happened. Studying 13 severely burned patients, as well as their families, Rochester, New York's Joanne Holter and Stanford Friedman find 10 of the 13 families involved had major psychological and social problems before the burn incident. 5 children, 5 mothers, 5 fathers were judged emotionally disturbed. 8 of 11 marriages were unstable. The gross emotional disturbances within themselves and around them almost seemed to propel the children into the tragic situations that resulted in their burns. Most childhood burns can be attributed to either a true accident, a situational crisis, or child abuse. And each of these categories, the authors believe, demands a different management approach. Because true accidents are usually limited to well-adjusted children from stable families, office psychotherapy should deal directly with parental guilt feelings and the child's fear of dying or becoming ugly, even unlovable. Seemingly unimportant gestures like leaving a nightlight on or a radio on all night may help to reduce disorientation, a common occurrence during acute phases of the burn. And any and all major procedures should be discussed with both the child and the parents. In situational crises, the child appears prone to injury because of pre-existing stresses within the family. Psychiatric counseling and help from various community agencies should start during hospitalization. After discharge, the homemaker service can be used to relieve disturbed mothers of some child care and housework. Public health nurses can help care for the child. Counseling should continue for both parents and children. Of prime importance in an abuse burn is the child's future protection. A continuing relationship with a physician and various community services can reduce the danger of further trauma. Child abuse, the authors note, is often a cry for help, an expression of parental frustration, anger, and tension at times of stress, rather than a reaction to a child-specific behavior. Before concluding this issue, we'd like to thank Drs. Baxter, McMillan, and Ziram, and the Cook County Graduate School for cooperation in recording and disseminating this material. Also, may we note that the American College of Surgeons sectional meeting in Washington, D.C. will occur March 16th to 18th. An audio digest will be on hand with microphones and recorders to preserve and relay the highlights of this important surgical meeting. The Audio Digest Foundation, a nonprofit subsidiary of the California Medical Association, produces audio digest surgery twice each month, along with 7 other programs of postgraduate tape-recorded medical information. All material presented in this issue is copyrighted, and further tape duplication is prohibited.